imagine going through like cycle after cycle of unexplained infertility. You pass every standard anatomical test, every hormonal test with flying colors.
Right, you basically check all the boxes.
Exactly.
Yeah.
You follow all the rules, and you're told everything looks perfectly intact.
Yeah.
But, well, beneath the surface, your own immune system is quietly treating your pregnancy like a virus.
It's an incredibly frustrating reality for so many people.
It really is. So welcome to today's deep dive. For you listening, our mission today is to really unpack a fascinating stack of medical abstracts, clinic notes, and immunology journals.
Yeah, there's a lot of really dense material here.
So much. But we're using it to explore this massive, often completely overlooked hurdle in family planning. We're diving into exactly how the immune system interacts with fertility and recurrent miscarriage.
Which is such a crucial topic.
Okay, let's unpack this.
Yeah.
We're moving away from just looking at reproductive anatomy, right? We're going down to the cellular level.
Right, the microscopic level.
Yeah, to look at the actual biological mechanisms at play when the immune system mistakenly interferes with the precise processes required for a healthy pregnancy.
It completely reframes how we think about human reproduction. I mean, we are so conditioned to view infertility as a purely structural or hormonal issue.
Like a plumbing problem or something.
Exactly, like a plumbing problem or a chemical imbalance. If the fallopian tubes are clear and, the estrogen levels are right, we just assume it's all systems go.
But it's not always that simple.
No, not at all. From a purely biological standpoint, a developing embryo is a massive immunological puzzle. Because think about it, it contains genetic material that is entirely foreign to the mother.
Right, the paternal DNA.
Yes, the paternal DNA. So the question isn't really why miscarriages happen. The actual biological miracle is that a pregnancy is ever allowed to survive in the first place without being immediately attacked.
That is just such a wild paradigm shift.
Yeah.
I mean, we spend our whole lives relying on our immune system to be this ruthless internal security force.
Oh, absolutely.
Its entire job is to scan the environment, identify foreign genetic material like bacteria or a virus, and destroy it. But then suddenly, a fertilized egg arrives carrying 50% foreign DNA, and we expect that exact same ruthless security system to just, roll out the red carpet.
What's fascinating here is how the body normally handles that exact contradiction. In a typical healthy pregnancy, the immune system undergoes a profound, highly choreographed shift.
Oh, wow.
Yeah. It creates what is essentially a zone of immune privilege at the maternal-fetal interface.
The maternal-fetal interface, that's where the uterus meets the developing placenta, right?
Correct. And specialized immune cells, specifically things called T regulatory cells, step in. You can think of them as, the diplomats of the immune system.
The diplomats, I like that.
Their job is to actively suppress the aggressive immune cells, telling them, stand down, this foreign DNA is actually safe. They essentially teach the mother's immune system to tolerate the pregnancy.
Right, so the embryo can actually implant.
Exactly. It allows it to implant and build the critical blood vessels needed to sustain life.
So it's like having an ultra-high-tech internal security system where the bouncers at the door usually know exactly who the bad guys are. But during a healthy pregnancy, someone hands the bouncer a VIP list, and they let the embryo right through.
That is a great way to look at it.
But for the patients we are talking about today, those experiencing unexplained recurrent loss, that VIP list gets lost.
Yeah, it completely fails.
The security system goes rogue and mistakenly turns away the VIPs right at the door. It just aggressively rejects the embryo. And looking through these clinical notes, the wildest part to me is that this immunological warfare happens in total silence.
Complete silence, yes.
Like there are no obvious physical symptoms of illness. You don't get a fever. You don't feel achy or sick. Which makes me wonder, if there are no obvious symptoms, how long do people usually go before realizing their immune system is the culprit?
Unfortunately, the sources show it often goes completely undetected until after repeated miscarriages or, prolonged unexplained infertility. The silence is really the tragedy of this condition.
That's heartbreaking.
It is. The immune dysregulation we're talking about is highly localized to the reproductive system. So the inflammatory cytokines, those are the chemical messengers that tell the immune system to attack thrive. They're localized at the cellular level within the uterus.
So the rest of the body is totally fine.
Exactly. A patient can feel perfectly healthy, run a marathon, go to work, and have zero systemic signs of illness, while this microscopic immune battle is preventing an embryo from ever establishing a blood supply.
Wow.
Because it operates so quietly, patients will just endure cycle after cycle, loss after loss, completely unaware that the invisible barrier is actually immunological.
Which brings us to the biggest flashing neon sign in the data that something immunological might be happening, even if the patient feels totally healthy. The data points incredibly strongly to family history.
Yes, family history is huge here.
If your mother, your sister, or even an aunt has an autoimmune disease, your risk of pregnancy loss is significantly higher.
It really is.
That tells us there is a deeply shared genetic mechanism between a predisposition to autoimmune issues and the tragedy of miscarriage. You might not have the full-blown disease yourself, but you've inherited the genetic blueprint for a hypervigilant immune system.
That genetic blueprint is the key. Autoimmunity isn't just one single switch that gets flipped. I mean, it's a spectrum of immune reactivity.
Right.
So when a woman with that genetic predisposition encounters the massive immunological challenge of pregnancy, that latent hypervigilance kicks in.
The bouncers go on high alert.
Exactly.
Okay.
The T regulatory cells we mentioned earlier, the diplomats, they fail to do their job properly. Instead, aggressive cells like natural killer cells or Th1 helper cells flood the uterine environment.
And that causes inflammation.
Massive inflammation. They create a highly inflammatory state that either prevents the embryo from implanting at all or it damages the fragile early placenta, which ultimately leads to a miscarriage.
But this hypervigilance isn't just some abstract concept floating around in the genetics. It shows up as very real, measurable diseases that drastically alter the statistics of a successful pregnancy. Here's where it gets really interesting, because the actual numbers in this data are staggering.
The numbers are definitely eye-opening.
Especially when we look at specific conditions. Let's talk about UCKD, undifferentiated connective tissue disease. The data cites this as the most common autoimmune disease in pregnant women, affecting up to 2.5% of them.
Right, up to 2.5%.
And those patients face a 9% to 21% risk of pregnancy complications or loss.
The term undifferentiated is really important to decode here. In rheumatology, when we say undifferentiated, it means the patient's immune system is actively producing autoantibodies.
Meaning antibodies that attack their own cells.
Yes, specifically in their connective tissues. But their symptoms and blood markers don't fit neatly into the diagnostic criteria for a classic disease like lupus or rheumatoid arthritis.
So it's kind of ambiguous.
It's very ambiguous. But the clinical data is telling us that despite that ambiguity, the danger to a pregnancy is incredibly concrete. The immune system is still producing those rogue antibodies.
And those antibodies target the pregnancy.
Exactly. They can target the placental tissue, causing microclots that literally starve the developing embryo of oxygen.
That makes total sense. I mean, if your body is making antibodies that attack your own tissues, it's not a huge leap to see how they would attack the rapidly growing, highly vascular tissue of a new placenta.
Not a leap at all.
And that ambiguity explains so much. A patient might just have, like, mild joint pain or some fatigue things anyone would just write off as being tired from work. But underneath, they have this undifferentiated condition causing a 21% risk of complications.
And they're completely unaware that their subtle joint pain is biologically linked to their fertility struggles.
But wait, here is my pushback on this. Conditions like Sjögren's syndrome or systemic lupus erythematosus SLE, they are also flagged in this data. But those are major systemic diseases. Wouldn't a patient already know they have them before trying to get pregnant? Or can these just hide in the background too?
Well, often they do know because the immune dysregulation is more defined, and consequently, the risk to the pregnancy often scales up dramatically.
Okay, that makes sense.
Sjögren's syndrome, for instance, is classically known for causing dry eyes and dry mouth because the immune system attacks the moisture-producing glands. But systemically, it creates an incredibly hostile environment for placentation.
I want to look closely at the math on Sjögren's syndrome because it really stopped me in my tracks.
The relative risk is astounding.
It really is. The data lists a relative risk, or RR, of 8.85 for miscarriage. That means a woman with Sjögren's has almost 9 times the normal risk of experiencing a pregnancy loss compared to someone without it.
Almost a 900% increase.
Yes. And it gives a 95% confidence interval of 3.10 to 25.26. So mathematically, even if we take the absolute lowest, most conservative end of that estimate, a woman is facing over 3 times the normal risk.
And at the high end, she could be facing 25 times the risk.
That isn't just a slight bump in the statistics. That is a blaring siren.
It is a massive red flag. When you see a relative risk approaching 9, it tells you that the biological mechanism at play, in this case, the specific autoantibodies produced in Sjogren's, like anti-SSA or anti-SSB antibodies, are directly and aggressively interfering with the pregnancy.
So it's a direct attack.
A very direct attack. These specific antibodies can cross the placenta and cause severe inflammation, or they can trigger blood clots in the microscopic vessels trying to feed the embryo.
So the immune system isn't just being slightly uncooperative.
No, it is executing a targeted strike with overwhelming force.
Okay, so we've established that an overzealous immune system can completely derail a pregnancy. And we know that whether it's an ambiguous condition like UCTD or a defined one like Sjogren's, the stakes are incredibly high.
Very high, yes.
The obvious next step is figuring out how to actually identify this in a patient. How do you, listening right now, find out if your own immune system is the invisible barrier? The clinical notes introduce the diagnostic key here, the reproductive immunophenotype panel.
That are known as the RIP panel.
Right. And it's described as a simple blood test.
If we connect this to the bigger picture, the RIP panel is the vital bridge between the absolute devastation of unexplained or recurrent loss and a targeted, manageable medical diagnosis.
Okay, so how does it actually work?
Well, the word immunophenotype literally means looking at the physical observable characteristics, the phenotype of the immune cells in your blood. It is a highly specialized blood test designed to map out exactly what your immune army looks like and how it's behaving.
Right, so we aren't just looking at the total number of white blood cells like you would in a standard physical.
No, much more detailed than that.
We're looking at the specific factions within the immune system. We are checking the balance. Are there too many of those aggressive natural killer cells circulating? Is the ratio of inflammatory cytokines way higher than the anti-inflammatory ones?
Exactly.
It's essentially taking a snapshot of the battlefield to see if the troops are in a peaceful, tolerant formation or if they're lined up and ready for war.
That's a perfect analogy. The RIP panel is looking for that hypervigilant state. It might measure the exact percentage of peripheral natural killer cells or look at the Th1 to Th2 cytokine ratio.
Theon's the bad guy here, right?
Basically, yeah. If Th1, which is pro-inflammatory, vastly outnumbers Th2, which is the tolerance-promoting cytokine, we know the environment is hostile to an embryo. It gives the physician empirical biological proof that the immune system is the culprit.
But this leads to something that is intensely frustrating when you really think about the logistics of modern medicine.
I think I know where you're going with this.
I mean, if this is just a simple blood test, a simple draw from your arm that can map out this incredibly vital immune data, why on earth isn't this step one? If someone is trying to conceive, why are we checking their structural anatomy and their hormones, but totally ignoring their immunophenotype until it's too late?
That touches on the defining tension in reproductive endocrinology today. Standard clinical protocols are inherently conservative,
Right.
and they are largely driven by population averages and cost-benefit analyses. Routine, comprehensive immunological testing for every single person trying to conceive would be incredibly expensive for the healthcare system.
I guess that makes sense from a purely financial perspective.
And for the vast majority of the population without these genetic predispositions, it would yield negative results anyway. Therefore, the medical establishment relies on a sequential, tiered approach.
Which is a polite way of saying they wait for you to suffer. They follow a flowchart that requires you to experience repeated miscarriages, as stated explicitly in these clinical notes, before they even consider looking at immunology. You basically have to prove that the standard interventions have failed at deep emotional and financial cost multiple times before someone finally hands you a requisition form for a blood test.
It is an agonizing reality for patients. They are essentially required to endure the trauma of recurrent loss to, quote-unquote, earn access to this deeper level of diagnostic testing.
That is just so backwards.
It is, and this is exactly why understanding the underlying cellular science is so critical. When a patient understands that an overactive immune response can be the root cause, and they know to look at their family history of autoimmunity, they stop being passive participants in a slow, conservative medical flowchart.
So you can push back?
Exactly. They become active, informed advocates for their own diagnostic journey.
And that shifts us perfectly into the action plan. because identifying the problem and understanding the diagnostic delay is only half the battle. If you are listening to this and recognizing your own story, if you have that family history, or you've been dealing with unexplained losses, what do you actually do?
That's the most important part.
The clinical data gives us a massive sigh of relief here, honestly. This is treatable. We aren't just identifying a terrifying biological problem with no solution. There are very specific, targeted interventions.
Absolutely. Once a RIP panel or similar diagnostic testing identifies an immunological misfire, the medical focus shifts to immune-modulating therapies.
And to be clear, we aren't talking about destroying the immune system, right?
No, not at all. The goal isn't to destroy the mother's immune system. Obviously, she still needs to fight off actual viruses and infections. The objective is to specifically downregulate the aggressive pathways that are targeting the pregnancy.
So what does this all mean in practice? I like to think of your immune system like a hypersensitive thermostat in your house.
Okay, let's hear it.
During an autoimmune response to a pregnancy, the heat is blasting at 100 degrees, creating an environment that is way too hot for an embryo to survive.
Right.
Immune-modulating therapies don't rip the thermostat off the wall. You still need heat in the winter to survive. Instead, these therapies just carefully dial the temperature down to a comfortable 72 degrees. You are modulating the environment to restore homeostasis so a healthy pregnancy can actually thrive without being scorched.
That is exactly how cellular immune modulation works. Depending on what the blood panels show, physicians might use things like low-dose corticosteroids to broadly dial down inflammation.
Or blood thinners, right?
Yes, low-dose aspirin and blood thinners to prevent those microclots we talked about from forming in the placenta. In more severe cases, they might use intravenous therapies like IV-Edge or intralipids.
And what do those do?
They essentially bathe the immune cells in signals that promote tolerance and suppress the aggressive natural killer cells. It is highly precise, customized medicine.
And to get access to that customized medicine, the clinical notes we are looking at outline a brilliant 3-step playbook for self-advocacy.
I really love this part of the notes.
Me too. They don't just say talk to your doctor. They give you the actual script. So if someone is sitting in their endocrinologist's office, the very first thing they need to say is, given my specific, personal, or family history of autoimmunity, do I qualify for immune testing?
You are immediately forcing the doctor to look beyond the standard fertility flowchart.
Right. You're making them account for your genetic background.
Exactly. You are establishing the clinical justification for the test right out of the gate, and the follow-up is just as important. The second question you must ask is, if this testing finds an immune issue, what specific treatments does this clinic actually offer?
I love that question because it's basically a trap in a good way. You are setting expectations before you even give a vial of blood.
Yes, you need to know their capabilities.
Yeah. You want to make sure you aren't wasting time taking a specialized test at a clinic that doesn't even believe in or, know how to prescribe the immune modulating therapies we just talked about. If they say, well, we don't really treat that, you instantly know you are in the wrong place.
This raises an important question about the boundaries of medical specialties.
Oh, for sure.
Reproductive endocrinology, which deals with hormones and reproductive structures, is a completely distinct field from immunology. Many standard fertility clinics are fantastic at IVF and hormone balancing, but they are simply not versed in the nuances of complex immune-modulating therapies like IVF.
Which leads perfectly to the third critical point of advocacy, asking if it's time to bring in a specialized reproductive immunologist.
Right. You ask, should we be consulting with a reproductive immunology specialist? It's taking control of the narrative.
You are essentially offering to build a multidisciplinary team. And what I found deeply refreshing in these notes is that they don't limit this multidisciplinary approach to just Western pharmaceuticals.
No, they don't.
The data points out that alternative and complementary medicine, specifically acupuncture and herbal treatments, play a documented role in modulating these immune responses.
It's a very holistic view.
The clinic notes even provide direct pathways for patients to consult on integrating acupunctures specifically for fertility support. They give number 2-126-85-0985 for consultations.
The inclusion of acupuncture in these clinical notes highlights a growing understanding of how the nervous system and the immune system communicate.
How so?
Well, acupuncture has been shown in various studies to influence blood flow to the uterus and help modulate systemic inflammation by engaging the parasympathetic nervous system.
Oh, wow.
Yeah. When you are dealing with a complex web of immune dysregulation, throwing everything at the wall, combining the cutting-edge cellular targeting of Western immunophenotyping with the holistic nervous system modulation of traditional medicine, it often creates the most robust environment for a pregnancy to succeed.
We have covered some intense, incredibly complex biology today. We started by revealing how the immune system, designed to protect us, can mistakenly view a pregnancy as a foreign invader, acting as a completely silent, invisible barrier to fertility.
And we broke down the mechanics of how a family history of autoimmunity serves as a massive red flag.
Right. We looked at the sheer mathematical reality of conditions like UCTD and Sjogren's, where rogue autoantibodies can increase the risk of miscarriage almost ninefold.
But we didn't stay in the problem. We mapped out exactly how diagnostic tools like the reproductive immunophenotype panel work to expose these hidden cellular battles.
And we detailed the biological mechanisms behind immune-modulating therapies that can literally dial down the inflammation and save a pregnancy.
Exactly.
For you listening, this deep dive is about giving you back your power. If you or someone you love is facing the heartbreak of recurrent miscarriages, or looking down the barrel of unexplained infertility and being told everything looks fine, you now have a completely new lens to look through.
You aren't just stuck waiting for another standard hormone check.
No. You understand the biology of the maternal-fetal interface. You have a specific, science-backed avenue to explore, and you have the exact vocabulary to walk into a clinic and advocate for the care you actually need.
The knowledge buried in these medical abstracts isn't just academic theory. I mean, it is a deeply practical toolkit. It validates the instinct so many patients have that something deeper is wrong.
Yeah, that gut feeling.
It gives you the scientific grounding to question the standard conservative protocols and demand a thorough investigation into what your immune system is doing in the dark.
But I want to leave you with one final thought to mull over. Something that zooms out from the individual clinical level and builds on the sheer scale of the biology we've unpacked today.
Okay.
We spent this time talking about reproductive immunology as a deeply personal, localized fertility issue. But if we look at the broader medical landscape, we know there is a well-documented modern global rise in general autoimmune disorders worldwide.
That is very true.
Human immune systems everywhere seem to be growing increasingly hypervigilant. So, if the human immune system is this tightly, and sometimes this problematically, woven into the very act of reproduction, could that global rise in autoimmune reactivity be a hidden underlying driver behind the broader worldwide fertility declines we keep reading about?
Wow.
Perhaps reproductive immunology isn't just about individual family planning in a single doctor's office. Perhaps it is the next major untapped frontier in human population science. Because if our internal security systems are increasingly turning the VIPs away at the door on a global scale, we're looking at a much more profound biological mystery than just a blocked fallopian tube.
It's an incredibly compelling hypothesis. It forces us to examine the intersection of our changing modern environment, the hyperreactivity of our immune systems, and the very future of human reproduction.
Something to think about until next time. Keep asking questions.